there. Good evening, everybody. My name is Dr. Randy Fink, and I'm a fertility gynecologist at New Life Fertility in Pensacola, Florida. And I am very happy to see all of you here this evening, as we are every Tuesday evening at this time. It's 5 o'clock Central, which means 6 o'clock on the East Coast. 4 o'clock in the mountains and 3 o'clock on the West Coast. That simple mathematics sometimes really gets to me there. Very happy to be here, as I am on every Tuesday night. And this is your time, folks. This is the opportunity for you and me to get together and talk about all those things that are important about you adding to your family, you having a baby, and both the scientific and the emotional things involved with getting that sort of thing done in our lives. I am live tonight from Dothan, Alabama, where we have a satellite office here. We have offices in Dothan, Alabama, in Panama City, and Tallahassee, and our home office in Pensacola. And yes, we are always happy. Would always be happy to see you virtually, over the internet, or at any one of our offices. And yes, we do take care of folks who are out of town. So by all means, please feel free to give us a call. By the way, we'll try to get to all your questions here tonight, the next hour or so. If not able to get to your questions, because sometimes they do start to pile up, there is an email address, and that is askfertilitywithfink at New Life, or I'm sorry, askfertilitywithfink at firstfertility.com. That's askfertilitywithfink at firstfertility.com. And we will get to your questions all at the top of the show next time. And that said, let's say hello to some folks here who are joining us. First to join is none other than the Bama Gal, and that is my beautiful mother and father in Mobile, Alabama. Thanks for being here this evening. Happy Tuesday to you. And of course, hello, a special super hello to Zenaida in Miami. Thank you for being here. Sharmila, it is always a pleasure to have you around. Hello to Vic and Kauser. Good to see you here. Medna Care, Angela Sack, thank you for being here. Hello, Rosa. Vic says, hello, Blaxican Beauty. Thank you for being here, my friend. I was not here last week, and so I hope you missed me as much as I missed you. But here we are back again. Summertime is a wonderful time for vacation, and things happen, like your family moves from Colorado to Florida, and that can sometimes take away from things. But boy, it's really hot outside, and so I hope you're enjoying the heat. It's that time of year for sure. Now, where I am, it tends to start to get a little stormy, a little thunderstormy in the afternoons, and by the evening. That was really the case in South Florida when I lived there. That happened in Colorado, and the same thing, of course, happens right here in the Panhandle. I got a question over the email, so let's jump right into that. And that came from Shanna, and it's really a question about Lovenox. Lovenox is a blood thinner, and I alluded to last week on, I believe it was on Friday. So on Fridays, I also do an Ask the Doc Friday, which means that you can throw your questions in to my Instagram at randyfinkmd. And I will answer your questions. It also gives me a chance to show some of my favorite pictures that I've taken that week. And so we get your questions answered. But we were talking about, there was a question about Lovenox, which is a blood thinner. And the question was, should I stay on my Lovenox? And my answer was only if you need it. And her question was, well, how do you know if you need it? How do you know if you need a blood thinner? Well, so in some situations, we will put you on a blood thinner when you have had a history that suggests there may be a clotting type problem. That clotting problem would be something like recurrent pregnancy loss. So if you've had several miscarriages, sometimes we will empirically start you on a little blood thinner. But the reason for that is because there are certain types issues that can be in your blood that make your blood want to clot. And that's what we call a thrombophilia. Thrombo means clot, philia means your body likes to. So a thrombophilia means your body likes to clot. There can be hereditary causes for that. There can be acquired causes for that. And so that's definitely something that we typically check when you have a history of recurrent pregnancy loss. If one of those things comes back positive, then we say, yeah, you need to be on a blood thinner. But sometimes we will use the blood thinner even without that history because it can increase the blood flow that's going to the uterus. Where I worked before, most people ended up on Lovenox just empirically. And my feeling is, yes, you can do that, but Lovenox or that blood thinner is not necessarily a benign medication. In other words, it can be dangerous. Having your blood overly thin means that if something happened to you, like let's say you slipped on the ice and fell, or heaven forbid you got into an automobile accident and you bonked your head on the steering wheel. Well, while you're on that blood thinner, that means that you're at a pretty significantly increased risk for developing a hematoma or a blood collection on your brain, and that's potentially a problem. So I don't recommend Lovenox routinely for people because there is no data that shows that it helps in the general population. But in my opinion, if you have had a history that is consistent with potentially having one of those blood clotting type problems, then it is not unreasonable to be on the medication. Question is, when do you stop it? Well, if it was first trimester miscarriages and we don't have evidence otherwise, then I would say you may want to stop it by the time you get out of the first trimester. But if you've had one of those blood tests that show that you have that type of thrombophilia, that your blood likes to clot, then you actually want to stay on that medication throughout your pregnancy because those risks start to expand a little further along in the pregnancy. So hopefully, Shannon, that answers your question when you go back and take a look at our recording tonight. Hey, we got a couple of different feeds here. We've got Facebook and YouTube right over here, and we've got my Instagram here for technical reasons. New Life Fertility's Instagram, we couldn't do a live feed on tonight, but this broadcast will be reshown on New Life Fertility's Instagram. Rosa asks, can a baby aspirin prevent preeclampsia, even started as late as 21 weeks of pregnancy? I had a subchorionic hematoma before, so I am starting it late. Well, the answer is, what we know from baby aspirin is that baby aspirin is one of the few interventions that have been shown to potentially prevent preeclampsia or certain types of other blood pressure related problems in pregnancy. Those are usually started in the first trimester. Most of the studies looked at starting them in the first trimester, but certainly if Rosa, you have a history of blood pressure issues in pregnancy, and you started that as late as 20 weeks, I would say that something is better than nothing. And the answer is probably so. I would think probably, but most of the studies really were done on starting that aspirin earlier on in the pregnancy, but better to be on it than not, especially with a history of a hypertensive disorder in pregnancy. If you have a question, please throw it up here and I am happy to answer. Angela says, can you still have a healthy pregnancy with a heart-shaped uterus and a 2-inch septum? Well, so you ask an interesting question there. A heart-shaped uterus. So, most of the time, a uterus is kind of shaped, let's say, well, here's the cervix, and the uterus kind of goes in here. There's an opening to a fallopian tube on both sides. A heart-shaped uterus would be something that kind of looks like that the cervix is down here, and what you're talking about is a septum or a band of muscle that is up here. So, we used to think that a septum was potentially a very bad thing to have in pregnancy, that it was a cause of miscarriage. And in fact, even still in my business, when I find a septum, I usually want to resect it. Now, how do you resect? How do you surgically treat a septum? Well, literally, it's just a band of muscle. So under a little anesthesia, we place a camera inside the uterine cavity and then use an energy source or even just a little pair of scissors to go snip, 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 and that band of muscle just opens right up. It's in the right hands. It's usually a very straightforward and very simple kind of surgery to do, especially if it's something that you're comfortable with. For a doc who may have never seen one, it might be a little bit more challenging. But in our hands, it really is a very easy thing to do. So I don't like to see a septum inside your uterus. And still, in some cases, people will present to us with recurrent pregnancy loss. And in that scenario, when they have a septum, I will always recommend that we treat it. Now, just in the last year or so, there was a very big study that was done that looked at the presence of a uterine septum or a band of muscle down the middle to see, is it really, strictly speaking, necessary to remove that band of muscle? Is it really going to have a beneficial effect on live birth? And what they found was that actually, in most cases, having the septum there did not adversely affect the pregnancy. So what you can imagine is the thinking is that, well, if you've got that band sitting there like that, then the concern is that the endometrium, the tissue that lines the inside of the uterus, may not be as stable over that muscular band. And then when the pregnancy tries to implant, it can cause a problem. Like it doesn't implant well and it ends up, resulting in a miscarriage. Well, the truth is that's probably not the case. Now, if you have a history of recurrent pregnancy loss and you have a septum, I will still suggest to you that we remove that septum, just because old habits die hard. And in that population of people who have already lost a bunch of pregnancies, maybe so. But in people who have not lost a pregnancy, who are incidentally found to have a septum, the outcomes of the research show us that nope, removing the septum really is not something that's necessary. So a heart-shaped uterus, something that looks like that, is really okay. It's kind of considered to be a normal variant. So there's another type of heart-shaped uterus, and that's what's called a bicornuate uterus. Bi meaning two, cornua meaning corners, and a bicornuate uterus is something that kind of the uterus looks like this, that there's one, we call this a horn. There's one horn here and there's one horn here. A bicornuate uterus may increase the risk of a preterm delivery, and it may increase the risk of what we'll call a malpresentation, or in other words, a breech baby, a baby that is sitting in the uterus butt first instead of head first. And most obstetricians do not, we no longer really routinely perform vaginal breech deliveries because the data shows us that the outcomes are not as good. If you can help it, you probably really want to avoid that under most scenarios. But a bicornuate uterus is not surgically fixed. We just leave it because that, like I say, that too is a normal variant. But if it's a muscular band, what we'll call a septate uterus, Angela, there is no reason that you can't have a wonderful, healthy pregnancy. And a nice normal delivery. But certainly with a history of pregnancy losses, I would think about, well, maybe we want to think about shaving down that little septum, and you are maybe at a little bit higher of a risk for having a breech baby, which might result in you needing to have a C-section for delivery. Sing Party of Three, hello, and hi to Crystal. Runner Girl Training, good evening. Thank you for being here. Hello to Lee Neck and the Styles family. Ain't NBB, Mrs. Villarreal, thank you for being here. Hi, FJ, and Vic says, what's an ideal prolactin level for a frozen embryo transfer? So let's talk about prolactin. The answer to that question is a normal prolactin level, which is usually, depending on the lab, typically under 20 or 19 or 21, depends on the lab, but thereabouts. Prolactin is the hormone that is secreted from your pituitary gland in your brain that results in the breasts making milk. When you are lactating after you have a baby, your prolactin level goes up, and that is the hormone that makes you make milk. Stimulating the breast or stimulating the nipples can result in producing milk because it produces prolactin. But interestingly enough, stimulating the breast, stimulating the nipples can also result in uterine contractions, because increasing the prolactin hormone also increases the oxytocin hormone, and that is the hormone that causes uterine contractions. And so that's why nipple stimulation is considered a form of cervical ripening in pregnancy, and may just kind of start making you have contractions. It's also one of the reasons that we don't recommend you be breastfeeding when you do an embryo transfer. Now, prolactin can also stand in the way of the normal hormone function that is the brain communicating with the uterus. And so if the prolactin level is high around the time of an embryo transfer, it does increase the risk for pregnancy loss. And so for that reason, I recommend that your prolactin level be normal. There are things that can make a prolactin level elevated. And so part of what we do in a fertility evaluation is to check that prolactin level. And indeed, it happens to be high in many people. What makes it high? Well, there are some medications that can make a prolactin level go up. Sometimes just stimulating the breast can make the prolactin level go up. And there is a diurnal variation, meaning to say, depending on the time of day. So if you come in for your screening labs and your prolactin level is high, we will ask you to repeat that blood test, usually in the first AM, with no nipple or breast stimulation for 24 hours, and then see what we have. Well, why do we care about the prolactin? And the answer to that is because you can develop a little growth in your pituitary gland, which is called an adenoma or a prolactinoma or microadenoma. They're usually very small. It's a little nodule that sits in the pituitary gland and secretes prolactin. And if you have that sort of thing, we want to know about it, because a prolactinoma can continue to grow. And as it grows, it can sit onto your optic nerve, because the pituitary gland sits right on top of where the optic nerve is in the brain, and can cause you to have visual issues, problems seeing. Usually it has to do with the visual fields. That's your visual vision from outside, as opposed to your fine vision right in the middle. So we want to know if what you have is a prolactinoma, or do you just make a little extra prolactin? Some people have what's known as pituitary hyperplasia. Hyper means too much, plasia means growth, that you just grow a few extra cells that manufacture a little too much prolactin. Both those things are really easy to treat with some medication. But the important thing to know is that if you have a prolactinoma, that's something that you want to follow to make sure it doesn't grow to the point where it begins to cause problems with your vision. How do you tell if you have a prolactinoma? It's an MRI. An MRI of the pituitary is the most direct way to determine if there is a little growth there in the pituitary gland. So the ideal prolactin level for an embryo transfer is normal. If it's too high, if it's abnormal, we don't want that. We want that to be normalized. So hopefully that's helpful there for you, Vic. Hi, Blaxican Beauty. I have been off methimazole for almost a month and just got my labs done, and so far so good. Was wondering if low-dose naltrexone or prednisone is worth adding to my protocol for inflammation. Well, you've got two different medications. Well, you're talking about three different medicines. So, first of all, this lovely young lady has a condition known as hyperthyroidism. The thyroid gland lives in our neck here and it controls the body's metabolism. When the thyroid hormone level gets too high, or when the thyroid's volume knob gets turned up, the thyroid starts dumping itself out and you become what's known as hypermetabolic. It can cause your heart to race. It can cause diarrhea. It can cause you to not be able to gain weight. And in fact, eventually and you're thinking to yourself, well, I want some of that. No, it actually becomes very bad for you. It can put you into something that's known as thyroid storm. And that's too much thyroid. You can become very, very sick in the intensive care unit, actually, as a result of that. So methimazole is a medication that is used to treat hyperthyroidism because it shuts down the overactive thyroid. If you were watching a couple of weeks ago, we talked a little bit about methimazole is not a medication that we want to use in the first trimester of pregnancy because it can be very harmful to a pregnancy. There is another medication that we would use and then typically switch you to methimazole when you're out of the first trimester. So we don't use that medication when you're trying to get pregnant. And so she's telling us that she stopped that medication about a month ago. I guess the thyroid did not shoot back up again. So hopefully the methimazole did the job there. But the other two medicines are low-dose naltrexone and prednisone. And let's talk about those two things. Low-dose naltrexone is a medication that is widely used in the anti-aging world. It is said to be an immune booster and is said to have very good effects on the immune system. There are people who are on low-dose naltrexone sometimes for years at a time, and people who take it for the long term say that they never get sick. They say they never get a cold, and that they just feel great from taking it. Some people taking low-dose naltrexone can get some weird dreams from it. You can it's a wonderful kind of treatment for pain. It is very good for inflammation. It boosts your normal immune system response. Where I worked previously, low-dose naltrexone was something that was used in really just about every cycle. Is there harm to using low-dose naltrexone? And the answer to that is no, probably not. Naltrexone is a medication that's used to block the opioid receptors in the brain. So if you're taking something like naltrexone, and then you have to be on a medication like oxycodone or fentanyl. Let's say that you're going to do your egg retrieval, and we usually use a little bit of fentanyl medication for pain after an egg retrieval. Well, your naltrexone is going to block that medication, and that's why usually we have you stop it before you reach the time of an embryo or of an egg retrieval, because we want that to be out of your body. There's not great evidence that shows how helpful and useful it is in the IVF or fertility world. So most practices do not use it as a matter of course. And the same as it pertains to prednisone. Prednisone is a steroid, and it's what's called a corticosteroid. It is not over the long term a benign medicine. It has an effect on your blood sugar. It has an effect on your bone density. It has an effect on your adrenal glands, which can have a ripple effect really all over your body. So I don't feel good about routinely putting people on prednisone. Again, there are some practices where everyone is on prednisone. Now what we know is that prednisone is commonly used in folks. I use it for people who have known inflammatory type conditions. So some people have issues with their thyroid that's called autoimmune thyroiditis or Hashimoto's thyroiditis. In that situation, your body is forming an antibody and attacking your own thyroid gland. And when that's the case, then then yeah, I know that you've got an inflammatory condition in your body. And so then I recommend, yeah, I do want to put you on prednisone. Prednisone is something that I'll often use for someone who's had recurrent implantation failure. So we typically look for reasons to put people on prednisone or low-dose naltrexone rather than putting everyone on prednisone or low-dose naltrexone. Is there a danger overall to being on it? Well, they're not harmful to pregnancy and they could just help. So I don't see a reason that you should say, no, I refuse to be on those because I think they're bad. I don't think they're bad, but I really support, using things if we can for good reason rather than just to cover a base that we don't know what's there. Hello to Sarah and to S. Atkinson, 702. Can you please discuss endometrial thickness for a frozen embryo transfer? Mine is 13 millimeters and I start progesterone in 2 days. Is that too thick? So the first question I would ask there is, did you have your cavity evaluated beforehand? Did you have a saline sonogram or a hysteroscopy? Because I want to know for sure that you don't have a polyp inside the uterine lining. As long as you had your cavity evaluated, 13 millimeters is not too thick. No, it's not. Once you start on your progesterone, then that lining is going to start to compact. It's going to start to shrink down and get smaller. Estrogen makes your lining get thick, and that's its job. It's to make a nice, spongy, warm, juicy place for an embryo to implant. And then progesterone's job is to take that nice spongy stuff and just to scoot it down to make it ready for the pregnancy and then to maintain the pregnancy. So we want that lining to be a minimum of about 7 millimeters. There are some people who have a problem in building their lining. And that can be for a number of reasons. Certainly if you've been instrumented before, like you've had a DNC, if you've had a few miscarriages, sometimes the treatment for those miscarriages, the care for those miscarriages can result in some damage and some scarring to the lining of the uterus that may keep that lining thin and make it hard to support a pregnancy. So that's sometimes something that we have to work with in order to get you there. So there is a level that's too thin. Is there a number that's too thick? Well, probably at some point there is a number. So let's say that number came back at 23 millimeters, so 2.3 centimeters. I would be saying, why is your lining so thick? Because that lining is abnormally thick, and it makes me think that there's something else going on, either in the cells that make up that endometrium, or possibly by having grown a polyp, which is a fleshy growth, a finger-like growth of tissue on the inside. But 13, I think, is fine. So I think you're in a good position there. So good deal. Sharmila asks, do all IVF pregnancies, are they all considered high risk? Can I get induced after my due date if I'm not getting pains? So the answer is there is nothing specific about an IVF pregnancy that makes it a high risk pregnancy per se. Now, there may be something about you and your individual situation that causes that pregnancy to be considered high risk. So let's say that you're, 43 years old and you do IVF and you get pregnant. Well, 43 years old is considered to be a high risk pregnancy because as we mature, things like the placenta can start to be challenged a little more readily than they do when we're younger. And the placenta is, of course, the source of all blood flow and the source of life to the pregnancy. The placenta ages more quickly as we ourselves are older. So in that scenario, yeah, we may say that you're a high risk pregnancy. But just because you had IVF does not mean you're high risk. Now, some obstetricians will treat you that way. They may send you to the high risk specialist to have you get your ultrasounds done there. There may be some extra testing that they do just to be overly cautious. And the reason for that is because they know that you invested a lot, right, in order to achieve a pregnancy through IVF. So they just want to give you every chance to, just to make sure that everything is okay. But the IVF pregnancy itself, just because it's IVF does not make it high risk. Now, you ask also here about due date and about induction. So your due date is calculated at 40 weeks of pregnancy, 40 weeks, which is actually 10 months, not 9 months. So that's why your OB is always going to tell you how many weeks pregnant you are and never how many months, because weeks is really what it's all about. And these weeks are based on life cycles. And so if you have a spontaneous pregnancy, it's based on the first day of your last menstrual period, even though you didn't actually conceive, you didn't ovulate until 2 weeks later, and that pregnancy probably didn't implant until about a week after that. But in terms of that whole life cycle, it's 40 weeks from the first day of the last menstrual period. Now, if the cervix is starting to dilate, or I should put it this way, if the cervix is what we call favorable, then after your due date, after that 40-week mark, there really is no advantage to keeping you pregnant. In fact, there may be some disadvantage, because as we pass the due date, bad things start to happen to pregnancies. Now, not all pregnancies, but remember, the placenta is an organ like any other organ in your body. And your placenta has a limited lifespan. It is really only built to support that baby while that baby is inside of you. And the human body knows that that pregnancy is 40 weeks from the first day of the last menstrual period. So once you start to get beyond that due date, you run the risk of the placenta starting to get tired. And when placentas get tired, blood flow stops flowing to babies. Babies stop growing. Placentas can start to separate. There can be issues. Frankly, sadly, babies can die on the inside, and that's something that nobody wants to have happen. So most obstetricians now will say, okay, if you make it to your due date and your cervix is favorable, and I'll tell you what I mean by that in a second, then let's just go ahead and get you delivered. Sometimes if your cervix is favorable, we can even put you into labor just by checking the cervix in the office, and that's called stripping the membranes. Also, some of that depends on what your GBS, your beta strep status is. So you probably also know that at 36 weeks of pregnancy, we do a little swab to check for a bacteria that's known as GBS, or group beta strep. Basically, GBS is how we know who needs antibiotics routinely when they're in labor. Because GBS, or beta strep, is something that causes sepsis, or an infection, in the baby if the baby is exposed to it during the process of birth. And that can happen either passing through the birth canal, or even can happen during a C-section. So want to know your beta strep status. But as I started to say, if you make it to 41 weeks of pregnancy, most OBs will say, okay, we need to go ahead and induce your labor now, because by the time you're a week after your due date, we start to kind of get worried about what's going to be happening with the placenta there. And there is data that shows us that extending a pregnancy out to 42 weeks is associated with poorer outcomes for your baby. And what we want is for you to take home a happy, healthy baby. Now, what do I mean by a favorable cervix? So we looked at this analogy before. Here's your uterus and here's the cervix. The cervix has to do two things. It has to thin itself out, and it has to open up. The opening of the cervix is what we call dilation. The cervix dilates. So if we looked at your cervix when you're not pregnant, or at the very beginning part of pregnancy, you see like a little dot in the cervix. And that's, where we do a pap smear from. That little dot maybe measures about 5 millimeters or so, maybe 6, 7 millimeters. Very small. But that's what dilates up to 10 centimeters for the baby to be able to pass its way out, which is amazing. It's really an amazing, fantastic little organ. Effacement is the thinning out of the cervix. And so as the uterus gets more ready for you to have the baby, it starts going through some chemical changes. And those chemical changes cause the thick tissue that makes up the cervix to start to get softer. And as it softens, it starts to thin. And then it starts to open up a little bit. So when I say stripping the membranes, what that means is that when we check your cervix, fingers go in the vagina. We can actually place fingers inside the cervix and can take a measurement. And you just kind of get used to doing that, being able to measure with your fingers what a cervix feels like. If it's loose enough, if it's open enough, if it's effaced and it's soft, that's what I mean by a favorable cervix. And that sort of thing. Sometimes you just kind of loosen up the cervix like that, and it can just cause you to go into labor. People also ask, well, what about sex? Does sex? I've been told that sex helps people get into labor, and there's conflicting evidence on that. But I will tell you, in my experience, the answer is yes. Yes, it actually does. How does that work? Well, semen is full of a little chemical in the body uses that's called prostaglandin. Semen is full of prostaglandin. Prostaglandin is what stimulates the process of the uterus beginning to thin and starting to open. And ultimately, it's what causes you to have cramps, and potentially even it's the stimulus for labor. So if we do a combination of things like stripping the membranes, like opening the cervix up, and then you go home and have sexual relations, there's a pretty good chance you're probably going to go into labor that night. Routine sexual intercourse at term, which means after 37 weeks, can have an effect of helping to ripen the cervix and prevent your pregnancy from going beyond or much beyond its due date. So I do think, so long as you're comfortable, that it's fine to do. Hello to Ariel. Nice to see you tonight. It's been 8 days since stopping my Provera and still no cycle. Well, so let's talk about what Provera does and how it does it. Provera is a type of progesterone. It's actually what's called a progestogen. It's a synthetic form of progesterone. So under normal circumstances, let's say normal circumstances, you're not pregnant. Your ovary releases an egg. That egg hangs out. It waits for sperm to come along and fertilize it. If sperm fertilizes the egg, then woohoo, you're pregnant. Your brain says, great, do all those things that you do when you get pregnant. And if not, it says, we're not pregnant. All right, fine. Shut off the hormones, clean everything out, and we'll start again fresh next month. And that's the signal to have a nice normal period. Well, you may know that we can check to see if you've ovulated by measuring your progesterone level. When the progesterone level is typically above a 3, that means that you've ovulated. So you've got a level of progesterone here, and that is coming from the area in your ovary where your ovary released the egg, and that's what's called a corpus luteum. The corpus luteum is what makes your progesterone. So your level is here unless it realizes that you're not pregnant, and then the level drops. And it's that drop of progesterone that stimulates your period. So when we give you Provera, we're giving you a dose of progesterone so that your level gets here. And then when you stop it, that level drops. And that should stimulate your period, or at least what we call a withdrawal bleed. Now, there are some circumstances when people will get Provera and they will not bleed. Really, in order to get the Provera or the progesterone to make you bleed means that you have to have enough estrogen that's in your body. So, Ariel, I would ask the question, gosh, I wonder what your lining looked like. Did you have enough lining there to be able to build did you have enough estrogen to be able to build a lining so that when you took your progesterone, it actually did cause you to bleed? There are some people who will take oral progesterone, but for whatever reason, they just don't absorb it very well. And so if you don't absorb it correctly, then it may not cause you to bleed. So in the older days, what we would do is instead of giving you the Provera, we would give you a shot, usually 150 milligrams of the progesterone in oil. Well, we don't really like to do that. It's more expensive for one thing. It's a shot in the butt, and nobody likes that. It's progesterone in oil. It doesn't feel good. But people who have what's known as hypothalamic amenorrhea means that, well, they've got a problem in their pituitary gland where the brain is not talking to the ovary and telling the ovary to make estrogen. And as a result, you don't grow a lining. And if you don't grow a lining, then all the progesterone in the world is not going to make it slough off. So, Ariel, I'd want to know what's the situation there with your lining, and why were you given the progesterone to begin with? Most commonly, we'll use Provera to get somebody to have a bleed who simply just isn't ovulating. That if your ovary doesn't release the egg, then you don't make that what we call the corpus luteum in the ovary, and you don't end up having a bleed. And so we can make that happen by giving some progesterone. So that would be my question there, Ariel, wondering what's going on with your lining. Did you have enough estrogen to be able to build that? Hello to Deanna. Here's a question. What if it's a fundal fibroid that pushes down on the middle of the uterus that makes the uterus look like it has a heart shape? Well, so typically when you do something like an HSG, a hysterosalpingogram, we can, and that's where, they place a little catheter inside the cervix and push some dye inside the uterus while taking some special x-rays. And that shows us what the contour of the uterine cavity looks like. 3D ultrasound is also an excellent way to determine, but it should be pretty easy to figure out if there's a fibroid that's pushing down on the endometrium. Now, if it is a fibroid, what's a fibroid? It's a ball of muscle. And 70% of women have some evidence of fibroids. How does that work? Well, muscle. Think about your bicep muscle here. You can feel that little cord of muscle that is your bicep. Well, muscle comes together in little sheets. And these sheets form a little hollow organ, and that organ is the uterus. Well, sometimes because the cells can get shuffled around, instead of forming a nice sheet, it can literally form a ball. And that's what a fibroid is. Fibroids themselves are not necessarily problematic because, again, 70% of women have fibroids. They are more common in African American women. There is some hereditary or genetic component to having fibroids, but finding some evidence of fibroids is very, very common in a uterus. In most cases, fibroids are not problematic to pregnancy, but they can be. So if that fibroid is inside the cavity of the uterus, then it's taking up real estate that a pregnancy wants to use to implant. So in that scenario, we usually want to treat it. If it is distorting the uterine cavity, then, most of the time we want to treat that because we don't, that distortion of the uterine cavity can cause problems in pregnancy. There are some other scenarios. Fibroids tend to develop their own blood supply. And so women with fibroids often have heavier menstrual periods. And so that's an indication to treat them. There are medications that can treat that as well as surgery. But I would think here, Angela, that should be able to tell pretty readily whether it's truly a septum in your uterus or whether it's a bicornuate uterus or if there is just a fibroid sitting up there that's pushing down. most of the time by imaging, we ought to be able to figure that out in a pretty straightforward fashion. So great question. Hey, it's about a quarter till the top of the hour. Thanks for being here on Fertility with Fink. We're here for about another 15 minutes, as we are every Tuesday. I am Fink. You are friends, and this is Fertility with Fink, formerly known as Fink and Friends. And please ask your questions here. And if I can't get to them on the show tonight, feel free to email. And that's askfertilitywithfink@firstfertility.com. Earth Girl Peace, hello. And let's see, do you recommend going to a baseline without starting the cycle after stopping Provera? Well, so it depends on what you're going to do. So some people, let's say that we're talking about ovulation induction, right? So we know what ovulation induction is. That's where we give you some pills, sometimes a little shot, to cause you to release at least one egg, sometimes more than one egg. That's ovulation induction. We want to make sure that you ovulate because we're trying to get you to release an egg, because you need an egg there for sperm to be able to fertilize it. And what we know as super ovulation, we're trying to get you to release more than one egg. So we're giving more targets to that sperm to increase the probability of you getting pregnant. So if you don't have a period, if you don't, let's say you don't get periods, you can go ahead and start ovulation induction or do a baseline without having to have that withdrawal bleed, without having to use that Provera. Now, sometimes people will say, well, let's look at your lining. If your lining is super thick, well, then maybe you do want to kind of mow the grass there. And that's what that period will do for you. So I think it may be that kind of scenario. Earth Girl Peace says, I have cystic fibrosis, but I'm very healthy. Fabulous. I did an embryo transfer, and I'm now pregnant with twins. So my doctors see me as high risk. And yep, having twins is a criteria for it being a high risk pregnancy. Is it crazy to ask for lifting restrictions at work? Well, so it's a good question. There is no specific number that I can give you that I would say, oh, obviously you're pregnant, so you clearly can't lift more than 17 pounds. Where did that number come from? That's not something that you can study, because everybody's every body is different. So everybody's, ability to lift, everybody's back is different. So, you kind of have to be judicious with that. But no, I don't think that that's unreasonable at all to ask for lifting restrictions, because twin pregnancy is a high-risk pregnancy. There are lots of things that can happen in a twin pregnancy. Preterm labor is, one of the more common things that we have to worry about when it comes to multiple gestations. And so the more active you are, then it may be the more that you're potentially predisposed to preterm labor, although I can't say that with certainty, and that depends on individuals. But, as you get more pregnant, your center of gravity is going to change, and that happens with even a singleton pregnancy. But when you have two babies in there, much more quickly, your back has to be working overtime in order to just keep you standing upright. Pardon me, our spine is what keeps us upright, and we have a normal posture. But when you add a bunch of poundage from two babies and a placenta and all that fluid that goes inside of it, right in the front there, your lower back is going to start paying the price. You will be feeling that in your lower back. And certainly if you're leaning down or bending over or kneeling, as you should be, to do lifting, it increases the possibility, increases the risk of injuring your lower back, or of bumping your belly. And of course, as you get more pregnant, even with a singleton pregnancy, as that center of gravity changes, your risk for fall increases as well. And so when you're lifting and leaning over and doing things like that, you're at an increased risk for a fall. Most employers don't want to have anything to do with that risk. So usually if you say, hey, I'm pregnant with twins, I have a high risk pregnancy and I'm worried about lifting, they will say, take this form to your doctor. You can have it filled out and they won't make you lift because, like I say, they don't want to have anything to do with that kind of liability, Hello to Mohi, if I never know how to say it, but it's nice to see you. Medicare, thank you for being here. We are specialized, medical billing. Okay, nice to meet you there. Bryn Hojam says, I'm 11 weeks pregnant on Thursday. Can I continue my progesterone and oil every other day until I'm 14 weeks? You can, but you don't need it. So your placenta has taken over making progesterone for you by the time you're about 9 weeks pregnant. So remember, initially, that progesterone comes from, what do we call it? The cyst in the ovary, the corpus luteum. If you've done a medicated cycle for embryo transfer, then instead of your ovary making that progesterone, we're giving you the progesterone in the form of the progesterone and oil. But the placenta takes over by 9 weeks. So in most programs, by 10 weeks, you're done with progesterone. You just don't need it anymore. If you wanted to stay on it, I don't think it's going to harm anything, but you shouldn't need it at all. Nor would I continue to check levels of progesterone at that point, because the numbers that we see then don't correlate with any outcomes. You should be in the free and clear by that point, and it should be okay to stop. Best of luck to you there. Hey, Lexi, nice to see you up in the Carolinas. Florida girl, thank you for being here. I sent a question through email. I don't know if you received it since I'm just joining. I don't know if I saw it, quite frankly. Maybe it was if your question might have been about Lupron. There was also a question there that had to do with where is an inexpensive place to get Lupron, and unfortunately that one I can't answer because all the pharmacies are different. So if insurance covers your medication, then the insurance company will tell us where that prescription has to go. If not, usually we get these medications from our fertility pharmacies, because fertility pharmacies typically discount these things deeply. The pharmacy that I will shout out to is called MDR. The MDR pharmacy, and MDR will match any price on a medication. So if you would, if you contact MDR, my suspicion is that if are not the lowest price, they're certainly a low price, because if you find one lower, they'll match it. That's MDR. Pharmacy. Other than that, I got to say, unfortunately, I don't know much about the individual costs for medications at all the different pharmacies, but MDR typically has very good prices. Hi to Linnea, Sarah, and Shada. Hey, Shada, nice to see you this evening. I'm late. What else can we look at after multiple miscarriages of euploids? So that really is one of the most frustrating things that we deal with. Why does someone who has chromosomally normal embryos still miscarry? Well, so, there's an evaluation that goes along with that. There are some blood tests typically that we look at that look to see if there's one of those issues with blood clotting in the body. I would want to make sure that your ultrasound looks normal, that the fallopian tubes don't have fluid in them. We know in your case that we deal with endometriosis, but endometriosis is more a concern for an implantation problem than it is for an embryo implanting and then not growing. So we always say that, it could be an embryo issue, even though we believe those chromosomes are normal. But the other thing that really comes right to mind, I'd want to know that your uterine cavity was normal with a hysteroscopy and a biopsy to make sure there's not a chronic inflammation on the inside. But we start really thinking about, is there an autoimmune reason that the body is rejecting the pregnancies. So things that we talked about a little earlier, prednisone, low-dose naltrexone, those are very good ideas. Tacrolimus is probably the most important thing in your situation. Shada. Tacrolimus is a medication known as Prograf. I hope that you were on it already, but Prograf is a medicine that is given to folks who have organ transplants. Now, women of reproductive age can have organ transplants. It's not all that common, but the most commonly transplanted organ in a woman of reproductive age is going to be a kidney. And so when they looked at women who had had kidney transplants, for one reason or the other, they're not always the healthiest folks. And so you would expect that they may have some challenges with their pregnancies. But they found that the women who were using that Prograf or tacrolimus medication had a surprisingly good pregnancy outcome. And so once they started to look at it a little bit further, they realized that the same type of immune response that may be causing someone to reject a kidney or a transplanted organ is the same type of response that the body may be making to reject a pregnancy. And so taking tacrolimus can adjust that. It's called a T1 to T2 helper cell ratio. And should very much be a part of a treatment for anyone with either recurrent implantation failure or recurrent pregnancy loss. Should your midway estrogen level be over 200 after a modified natural FET? Well, anywhere kind of between 200 and, call it 200 and Sarah, really, let's actually say maybe 175 and 550, I think, is considered to be an optimum range. But there's really nothing about an estradiol level that's going to change the way we manage an embryo transfer cycle. So most places do not check those estrogen levels, because as long as the estrogen level was sufficient to make your lining thick enough, then that's really all you need to know from it. So testing the estrogen level further on doesn't really change outcomes. Now, the other thing is that a lot of folks who watch this program have been on a modified natural transfer cycle where they used letrozole for ovulation induction. Letrozole lowers the estradiol level. So if you, Angela, took letrozole for your FET, then I would expect that your number is going to be artificially low. And it's one more reason that it's really not so much a meaningful number. Let's see, could we do PIO with a modified natural cycle to get extra support? Yes, you absolutely can. Some people do choose to use a little extra progesterone in the form of PIO, even though in a modified natural cycle, it's your body making your own progesterone there. But can you use extra? Yes, absolutely you can. Expecting-ish, hello there. Lupron was a question about, well, you know what, Florida girl, I did not see that one. A question about Lupron versus Orilissa after a chemical pregnancy with 2 months of Orilissa. So basically, it sounds like you did some suppression for endometriosis, and then you did suppression for endo, and then you got pregnant, but it was a chemical pregnancy, unfortunately. And I'm very sad to hear that. In my opinion, and there really hasn't been great evidence to support this one way or the other, but in my opinion, I think using suppression gets you, let's say, 6 months worth of suppression. So I didn't see your question there specifically, so I hope I'm answering it, but I would not think about having to do suppression again for another 6 months. Would you be better off with Lupron versus Orilissa? I don't know that you can say that. They really should be, according to the evidence, they should be equivalent. But Lupron is the only, for 30 plus years is the only medication that we had. So it was the choice. It's the big gun. It shuts everything down. It pulls out the plug. You got no more hormone. Sometimes we'll even add some letrozole to that because letrozole stops you from making estrogen in your fat cells. So the Lupron will tell the brain, no mas, while the letrozole that you take daily tells the rest of your body, don't bring us any more estrogen from any place else. So that may be a thought there as well. If I did not get to your question, excuse me for choking on you there. If I did not get to your question tonight, please feel free to email me, and that's askfertilitywithfink@firstfertility.com, because we are out of time tonight. Back to the top of the hour. Please join me next week, won't you? Every Tuesday at 5 o'clock Central Time, 6 o'clock on the East Coast. Remember, this whole fertility business, it's not the book of your life. It is not your novel. Really what it is that it's just a chapter. And what are we here to do? We are here to rewrite it together. Every step forward with love, every step forward with kindness, and every step forward with hope that tomorrow is a new day full of all new adventures. So until next week, thanks so much for being here. God bless. I'm Dr. Randy Fink from Pensacola. Good night.